Yeah, my name is Hyeon-Cheol Gwon, and this is Dr. Youngbin Song. As a junior faculty member of interventionist in the Samsung Medical Center. Then we have the Hyunjong Lee from Bucheon Sejong Hospital. So today, slide on the screen, please.
64.
No, not yet. Today, I prepared some BRS case for bifurcation. Dr. Lee, please introduce the case, please.
Yeah. 64-year-old male was presented with CCS2 evolved angina. He had hypertension. Baseline resting ECG showed no significant STT change. Next slide, please. Right coronary angiogram showed the mild stenosis in mid and distal RCA, and left coronary angiogram showed the diffuse significant stenosis in ostium to mid LAD. And big diagonal branch has a focal intermediate lesion, and the ostial stenotic lesion in LAD and diagonal ostium looks more significant in AP and LAO caudal views.
Next.
We performed the functional evaluation in this diffuse LAD stenotic lesion. Distal LAD FFR was 0.71 during maximal hyperemia. We could find the single step up, pressure step up in ostium to mid LAD during the full-back maneuver.
So I'd like to show the angiogram today. Angiogram, please.
엔지오 좀.
Angiogram on the screen. Yeah,
엔지오.
you can see an epicaudal view here. So definitely it's a proximal LAD lesion, calcification in the upward top of the LAD lesion. But you can see some disease in the left main too. So plaque seems to be crossing over the left main. Next view. This is not so tight, but a significant lesion covering from the medial LAD just above the septal. Maybe there is a lot of plaque, minor plaques all over the LAD. Another finding is the diagonal, also diffuse disease moderately, maybe 30 to 50%. But another important bifurcation in the diagonal lesion. So I think this is quite not a good case for stenting the diagonal. But actually, this patient is 64 years old, and I prefer to implant a BVS. So to implant BVS, I think there is a lot of issues for this. So if I finish the lesion first, the slide on the screen, please.
슬라이드.
그 정도. Next. Slide on the screen.
잠깐만.
Okay. So the LAD bifurcation lesion, there is a lot of chance to, after implanting the PVS or DES in the LAD, there is a lot of chance to dilate the side branch. But there is the final kissing ballooning is a usual technique for 마이크 바뀌었는데 소리가 usual technique for finalizing the result after sinus ballooning. But recently, part-side part technique, so-called final part repart technique, is available. The reported in bench test. So I think it's the good technique for BVS because final kissing ballooning usually oversized the scaffold proximal to the side branches. So I'd like to show some techniques and also the result of a final part for this patient. Next. Next slide.
Next slide.
So in bench test, actually, the part-side part technique was superior to kissing balloon technique in terms of the side branch also the occlusion or And especially eccentricity. This is very eccentricity is very low in after the part side part technique. So next slide. So another issue I found today is that after the IVUS examination, we found some plaque across the left domain bifurcation. So we are considering the LED ostial stenting with a small size stent or scaffold, or you may want LED to left main stenting with a larger size stent. IVUS, please give me IVUS, please, on the screen. IVUS on the screen, please.
IVUS.
Okay, this is a rapid pullback, 1 millimeter per sec from LED. Vessel size is 3.5. Here is the 3.0. The plaque burden just above the septal branch. Okay, getting better here. So about 30 to 40% stenosis. The diagonal comes from the 2 o'clock. So this is most severely diseased portion. So vessel size is 4.5. The lumen less than 3. This is ostium of the LED. Just stop the IVUS at the LED ostium. Yeah, this is LED ostium. Vessel size more than 4.0. Lumen size less than 3. So it's quite painstaking to finish the end of the scaffold here. What do you think? Do you prefer to cross over to left main or just stop at LED? Angiogram on the screen, please. Epicaudal.
Any comments from the panel?
I think I would cross over to the left main.
Crossover. Nobody wants to stop at the LED ostium?
Yeah, it seemed like you had some plaque in the distal left main, but I agree with you. I think if you're putting a scaffold particularly, you might want to consider stopping at the LED ostium because it's a pretty big circumflex.
Yeah, BVS is impossible for covered left main for the size sake. So anyway, I like to show the BVS technique, so I prefer to stop at LED. There is a risk of dissection LED ostium. But if there is a dissection, I will use the metallic stent from the LED to left main afterwards. And before that, I like to be very conservative. Dilated stent is tricky. Okay, next, Angel, next. So I was next. So I pre-dilated the LED with a 3.0, 20 millimeter balloon, 14 atmosphere. Next. Almost a full size pre-dilatation. Next. So you can see some compromise over filling defect at the ostium side branch. So anybody wants the side branch ballooning here? Yeah, I like to stay away from that actually. The long lesion, at least less than 2.5, maybe. In the IVUS, the diagonal ostium is 2.75, so the lower limb is smaller than that, at most 2.5, so long lesion. I like to stay away from that. That's why I wired the upper limb. Okay, anyway, there is a lot of debate, but the recent RCT showed that the pre-dilatation reduced improved the TB flow after main vessel stenting. Especially, I'm planning a BVS that is considered the large dimension of the struts. I think it's safer to pre-dilate diagonal. Next, 2.5 balloon. It didn't touch the ostium. Next, so pull back and pre-dilate with 6 atmosphere. I like to avoid the dissection. It'll compromise the procedure. Next. Okay, so actually my plan is to implant the BVS Actually, lesion is length is about 33, so we need to implant 2 BBSs. And 3 actually vessel size is large, but I started with a 3.0 balloon from the LED ostium because we cannot control the overlap if I implant the BBS distally first. So metallic stent is a kind of simple procedure. The BBS is getting complex. So this live purpose, I like to share with you this BBS case procedures. So I start with the 3.0 18 millimeter BBS. Maybe you can argue a lot for this procedure. I'm not sure I really can get the BBS, cross the first BBS in the LED ostium. I'm not sure. Of course, yeah, I measured it by the balloon. balloon 좀 보여줄래요? No. Yeah. Next. Balloon. Next. So this is a simulation. The proximal edge of the proximal marker is the LED ostium. So I think the overlap proportion is occurred in the distal to diagonal. Usually, I prefer to use 3.5 BBS, but the risk of dissection, the lumen size is less than 3.0. I think I should be conservative. Test. Okay, let's get angio. Angio. Sure. Okay, a little bit too deep, right? It's okay, but the scaffold is on the balloon marker, in the middle of the balloon marker. So this, I suppose the proximal portion is at the center of the circumflex. That's what I intending. Okay, test again. Test. Okay, inflation slowly up to a 6. 2, 3, 4, 6. As far as I know, there is about 1,200 or 400 cases so far since January this year. Deflate. So very minority. For fear of the stent thrombosis and the deliverability is the worse than the DES and this kind of problem. We need to think a lot of things before doing the procedure. Okay, let's see the result. Sure. Okay, it's undersized, of course, but there is no dissection. Maybe I can size up. There is a soft plaque covering the LED ostium, so there is larger than the lumen size, but there is some room to do that. So 12 atmosphere for 15 seconds. Okay. So proximal LED is underdilated. So I like to use the 3.5 balloon, post-stent balloon afterwards. Deflate. Okay. So let's simulate the second balloon, second stent. I like to balloon marker on the screen, on the scaffold marker, epicranial.
You can see the 2 platinum markers on the BBS.
Should. Yeah. So the option is 18 and 12, as you know. 12 is okay.
Ostium looks pretty good.
Pretty good.
Yeah.
Another issue, I use the undersized scaffold for proximal LED is the oversizing is really a good, very strong risk factor for diagonal ostial compromise. If I use a 3.5 scaffold, there is a higher risk of compromise. So before I recross the wire to diagonal, I need to be very conservative. So 15, this 12 or, okay, let's see what's happening.
Okay, we can hear you again.
Okay, you can hear it. Okay, thank you. So start.
Oh,
Okay,
yeah.
not so bad. Okay, I'm convinced. You are happy too, right? So there is two techniques. I like to have a balloon marker on the
Scaffold.
on the scaffold marker. Okay,
Okay.
that's okay.
Yeah.
Yeah, inflation,
Inflation,
slowly up to
yeah.
6.
2.
Actually, I cannot understand that why the nominal pressure of BVS is as low as 6. Deflation.
Deflation.
So maybe I need to recross the wire. Angiogram, please.
Yes.
Sure. Okay.
Looks good.
Actually, I hoped the diagonal is a little bit compromised, but it didn't. So I need to recross the LED with the side branch wire because this is very safe. But please remember that the proximal scaffold is not well expanded. So I'll try side branch wiring first. If it is not working, I do the 3.5 balloon part first for the
Post.
for the proximal LED. Okay? Talk. The reason why do the just try the part first is that I like to dilate more with the 3.0 balloon in across the diagonal. That's why.
Yeah, no, that's very elegant. The idea of now taking a short 3.5 NC balloon can facilitate.
Okay, this is
re-entry
wire
to the
prolapse technique. You can see wire prolapse technique. This avoids the wire undermining. It's an undersized scaffold proximally. Test.
Test.
Okay, looking at as distal as possible, not always possible. Okay, so to be frank, the side branch wiring for after PVS implantation is more difficult than bare metal stent because of the large dimension of the strut again. No. 테스트 막 하지 말고 내가 하라도 돼요. 테스트? It's kind of proximal.
Yeah, I
Kind of,
think
so
you're
let me
through.
try again. Yeah, I was through, but it's kind of a proximal. Maybe there is no other way to do that, but I'll try once again.
Oh, you're trying to cross on one of the distal struts there.
As distal as possible, but not
Yeah.
always possible.
Yeah.
Okay, let's finish with this. I'm not sure. So theoretically, as distal as possible, in reality, it's not always possible because the width is 0.18 millimeter covering the diagonal, so it's not always possible. So then I push the balloon again and the higher pressure. Inflation,
Inflation.
14,
14.
16,
16.
18.
18.
Okay. Okay, deflate.
Deflation.
Let's look at the under-expanded portion actually. Previous angel, please. Okay, plate. Under expansion, maybe just above the distally. Okay. Find the scaffold. This always. Okay, just above the scaffold. Okay, 18.
18.
You can use the NC balloon, but in the not calcified lesion, maybe stent balloon, it will work. Deflation.
Deflation.
Then apicaudal. Tester.
Yes.
Okay. I kept inside of a scaffold. 쏘지 말고. Okay. Inflation.
Inflation.
18.
18.
Yeah. Okay. Deflation.
Deflation.
So at this moment, epicranial 저거 2.5 블론 대기 2.5 블론 epicranial shoot. Yeah, still diagonal is okay. For the purpose of a live demonstration, I like to dilate side branch and then finish with the final part.
Will you re-IVUS?
So
Will you repeat the IVUS?
no, IVUS cannot cross to. It's difficult to get the IVUS down to a diagonal. So anyway, we pre-dilated the diagonal, so additional balloon does no harm.
No, I mean, will you
If
re-IVUS
you are
the
very
LED?
conservative. IVUS LED. Yeah, after optimizing everything.
Yep.
So I like to do the part technique for proximally. No, not actually. Deflation.
Inflation.
Actually, I do the final part.
Are you going to
So
take?
maybe for the purpose of a live demonstration, I do the IVUS now to look at the ostium of a distal main vessel. 이거 좀 다 뽑아줘봐요. IVUS 준비.
어.
Okay. Angio. Sure. Okay, it looks okay. There is a filling defect was gone away after side ballooning.
It looks really
So-
nice.
So, yeah, I'm not sure about.
would-
but definitely, I think there is some deformation in the main vessel LED BVS. I think it should be corrected afterwards.
Flushing.
Yeah, I would have a
0.5
low
mm
threshold to take a 3.5 NC balloon to the proximal part of that
no,
LED scaffold.
Yeah, yeah, sure. I'd like to finish with a 3.5 balloon. With the final part, including the bifurcation site. Flushing. Okay, I'd like to just show the ostium of a distal main vessel. The IVUS on the screen. IVUS still
IVUS.
there?
Yes.
IVUS on the screen?
Yes.
Not yet, not yet.
No, not yet.
Not yet. 굉장히 느리다 바꾸는 게. 응?
Okay.
큰 곳에 떼어주세요. 큰 곳에. On the large screen. Okay. Pull back. This is LED. Yeah, a little bit undersized, but it's okay.
Looks great.
So, okay, ostium, not okay, right? This is eccentrically, MLA was formed at the ostium of LED. Okay, so yeah, this is proximal location. Stop there. And 엔지오를 주고 사이드 브릿지 발론 하기 전에 엔지오 좀 보여줘봐요. So if you look at carefully before side bridge ballooning, this is before side bridge ballooning. Now after side bridge ballooning, after. I'm not sure. In my mind, frequently the scaffold is pulled to a diagonal side most of cases. So I like to recorrect it with the part technique. So
3.5.
3.5. The beauty of a part is we don't need to do the final kissing ballooning or mini kissing ballooning. That is standard technique for BBS because you don't like to overexpand the scaffold proximally. Anyway, by the book, by the paper, actually the location of repart, final part is very important. So just covering the carina, that's the beauty. So test.
Test.
So angiogram. Sure. Oh no, to distal. Test.
Test.
Okay. Angio. Sure. Yeah. Target is the stop 좀 시켜봐요. Is the proximal margin of the distal marker is aligned with the carina. This is covering about 1 to 2 millimeter of the carina, the reposition the carina back to our original position. So inflate.
Inflate. 4, 6,
10,
10,
14.
14.
Yeah. It looks like crossing the bifurcation. 18.
18.
Okay. 3.5.
Yeah.
Doesn't look so big. Like I say, even post ballooning after a BVS, I like to maintain some duration, some time. Deflation. Epicaudal view. Epicaudal view. I like to avoid. Oh, just there. Can you see? Yeah, just inside the marker. So I think this is the best we can get. So let's take angio here. Sure. Okay, epicranial. Okay. Sure. Yeah.
It looks beautiful.
That is filling defect again. Okay, but the filling defect side branch again. Anyway, I like to check the IVUS for the expansion of the BVS at the bifurcation location. So actually, the final part, repart or sequential part technique is still experimental technique. But I think BVS, that we can avoid the kissing ballooning, so we simplified procedures. Flushing. Okay. So today I used the 7 French guiding catheter just in case for the live demonstration, but usually I do it with the 6 French guiding catheter. As a transradial approach, of course. Okay. From the 1mm 풀백, 1mm. 어? 뭐? IVUS on the screen, please.
Not yet.
IVUS on the screen. Yeah.
Please IVUS image on screen.
Big screen. IVUS on the big screen, please. Big screen.
Okay.
Okay. Pull back, start. Okay. As you know, the IVUS is less sensitive to find a dissection or malposition for BVS. Just 2 lines. OCT, 우리 시간이 어떻게 되죠?
20분 남았습니다.
How long do you have? Actually, we can check the OCT for you. Anyway, the issue is that the expansion of BVS here, around here, right? I think it's much more expanded before, covering the ostium is going back to normal position. Of course, it's undersized here. Wow, this is really big. This is left main.
Yeah.
Okay. Okay. So let's see the LAD ostium again. LAD ostium. Oh, the pullback. Yeah, ostium still 3.0 expansion, and distally distally, a little distally, distal. Distal is 3.5. So that's what I expected. 3.0 stenting proximal, there is a very low risk of restenosis, I suppose. So how long do we have, and do you want me to check the OCT?
Is the Master of Ceremonies here who can advise us on how long we have?
This is Dr. Yoon. Dr. Kwon, you have 5 minutes more. So after 5 minutes, we will go
5
to
minutes
Seoul
more.
National University. So it's up to you.
Okay, so I'll okay, prepare the OCT. No, check the diagonal branch. That is much more interesting. I'll check the OCT 하지 말고.
Yeah.
Yeah, okay. Check the diagonal ibis. Flushing. Okay. IBUS for BVS is already very challenging. It's more difficult to get the IBUS catheter down to diagonal. For this case, it's very smooth. Yes, I'm very happy with it. Okay, IBUS on the screen.
Yes.
Okay, very good this time. Pull back. So yeah, diagonal
not
proximal, diseased. Still, I hope there is some room for that. Yeah. Okay, that's it. That's what I like to show you actually. So
Looks pretty good. Doesn't look like there are any
So,
dissections.
any? Yeah, I think so. Hopefully, yeah. Fortunately, I was very conservative to use the low pressure to keep the vessel open. Okay, I removed the wire and got the final angiography. Okay, I think it's good.
Can we have the angio on the big screen, please?
Yeah, please switch the screen.
Big screen, please. Angio on the big screen.
엔지오를 큰 스크린.
Interestingly,
Okay.
about more than 10 years ago, there is a randomized trial comparing the elite ostial stenting versus left main crossover stenting from the Catholic University Korea. Actually, it is the bare metal stent, but the result was the same. Result was the same. So we can do anything that you can select from the two strategy, I think.
Well, if there are any comments from the panel, we'd like to congratulate you for showing us a very interesting complex bifurcation case using BVS with great teaching points. So thank you very much.